not everything new is good, and it's important for us as a society, ISMICS society, to be leaders in innovation, but also to critically evaluate and find out what works and what doesn't work. And I can say that being on some of these consensus statements, it is a real eye-opener. Dr. Chang graduated from the University of Toronto, completed his internal medicine anesthesiology residency, and he then did cardiovascular anesthesia fellowship at University of Iowa. He's since become the distinguished professor at University Professor and Chair of Anesthesiology and Perioperative Medicine, and also as well as a Professor in Critical Care Medicine. Probably what he's best known for outside of his home institution is establishing the Evidence-Based Perioperative Clinical Outcomes Research Group, or EPICOR, that has looked specifically at outcomes. We've had a long relationship with Dr. Chang, and he's going to give the results of that in doing our consensus statements. And we kind of, in a way, both started together, and it has greatly benefited ISMICS to have these consensus statements, and he's going to give us an update now on the history of them with ISMICS and as well as our current status. Thank you.
Thank you very much, Francis. And indeed, it is a great honor and privilege for me to address to you for this morning regarding the reflection of the past 10 years of the ISMICS Consensus Conference. And particular honor for me to speak after the very inspiring address by Dr. Mack. And as he indicated often enough for all of us involved in administration too, there's always one quote I always use to my junior faculty and my colleagues. If you're not at the table, you'll find yourself on the menu sometime. So make sure that you engage. So how's that for the past 10 years? What can we reflect back on? Some disclosure, all my funding came from the Ministry of Health and the CIHR, and a small amount of funding from the ISMICS annually that we've been doing the consensus, but mostly from the EPICOR that my department and myself has invested in for our program. So I have no industry conflict. One aspect I do need to acknowledge, the Stay-Fast Consensus Conference for the past 10 years. Olori Alger, she's there, is tremendous support and able to hold all of us together. As you can see, she has to assemble the cardiac surgical team to work closely with me. And of course, my colleagues, Dr. Janet Martin and the EPICOR and the Medici program team, but not the least, also Carol Brasberg from the Innovation Journal has been for those years very supportive and fast-tracking some of our publication as well. So I'm going to very briefly bring back some of the evidence-based medicine guideline development so that refresh and actually echo some of the things that Dr. Mack has mentioned to you. And we're going to go over the 10 ISMICS consensus statement and its supporting evidence, what we have accomplished, and to update you on the TAVI and the off-cap CC, and to reflect on the future direction. In terms of evidence-based medicine, the IOM already indicated to us by 2020 that the roadmap for science and outcome for patient healthcare is on value. The value, i.e. of the outcome and the cost for any drugs, procedures, technology, and program we implement on patient have to be scientific driven on the healthcare program, aligned with the best practice and evidence. So who want the evidence nowadays when they walk into your hospital door? The 5P. The patient want evidence. They sometimes armed with much more literature than you can imagine. Our physician, as us, we want the evidence. As the provider from the hospital, the payer in our setting is Ontario, Canada, and the policy maker, some of the team and some of the policy regarding funding and not funding the procedures. If we trace back to the evidence-based medicine, the father of evidence-based medicine, Dr. David Sackett from Hamilton, who actually coined the word evidence-based medicine and clinical epidemiology at McMaster Hamilton, is the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. When we talk about evidence and publication, we all are in a scientific field. As Dr. Max said, this is a group that is very innovative and also in the cutting edge of science. We have mountains of basic science literatures, we have mountains of clinical study, and we have many, many guidelines and practice. How many of those are the continuums that I comment about in this editorial that reach the patient and benefit the outcome in terms of the values of complications and costs? 2,000 RCT per year published. How fast you can read those and how much you can digest and synthesize the evidence every year with a proliferation of the evidence into your office or into your computer. The 5-step by the evidence-based practice, this allows us as clinicians, when we want to do an intervention, either be it drugs, a technique, or procedures, we need to ensure that we define the clinical question when we design those studies, i.e., is the patient population we indeed intend to treat? What are the intervention? The key comparator. What is the current gold standard? TAVI versus open surgery or TAVI versus medical management? And what are the outcomes? The hard, relevant outcome that patient care and meaningful to the patient and to us. Find the best available guide, evaluate, know some of your key epidemiology, know some of your basic statistics, know when you read the literatures regarding the validity of the study that you read, the importance of the size of the effect, and reliability for those evidence. You have to apply the evidence, integrate the value in your local context with your resources and circumstances. And then you need to continuing to re-evaluate the process so that it got sustainability in the program that you implement. Very briefly to refresh with you, the determinants of the quality of evidence is determined by the type of study design and the methodological quality. Of course, if you want to do an intervention procedures, RCT is the way to go for a drugs, technique, or procedures, i.e. are they properly randomized? Even randomization have many levels of randomization. Or often enough in our surgical world, unfortunately to a certain degree, often they are descriptive study. And even when they come for analytical analysis, often enough there are many, many papers on cohort study. We look at exposure for a technology intervention, either be off-cap, either be TAVI, either be VET, and we look at the outcome in a cohort study, or case control study, or cross-sectional study. Often enough, review systematic meta-analysis. If they are good quality evidence and publication, we can synthesize. But there's a misleading and misunderstanding of quality of work. There are many papers out there, rapid publication for meta-analysis, bad apple out there. If you're adding this up, it's like comparing apple and orange. They don't add up. So garbage in, garbage out. So we do want to aim for the highest level of evidence. Level A always by the ACC AHA guideline is that the level A evidence, randomized controlled double-blind. Understand that difficult for surgical procedures, but in cardiology and many of the other fields, that's the highest quality to reduce the bias and distribution. And then the randomized control, level B for control study, and level C are expert opinion. Every time you read a guideline or a consensus for a publication, there are recommendations. When the recommendation, read behind the fine print, read the statement. When you read the statement, make sure they define for you or not the level of evidence supporting the statement in that journal or that publication behind the recommendation. The world in evidence-based medicine and in epidemiology are converging. We are now grouped into what the graded system, moving away from all different CHES, CHC. The new grade system actually is the new consolidated approach for doing evidence-based medicine. So what are the background for ISMICS and our consensus with our program of the EPICOR and the Medici? Trace back to some of the evolution. Anesthesia and surgery are truly working as a team, as what Dr. Mack was inspiring us to do. You look at the deep hypothermic beating heart surgery is the beginning of racing through, submerging in the ice bath back in the old days in the 40s and the 50s. We're now doing beating heart as well. 1953, May 6th, the John Gibbon machine revolutionized the whole changes in the cardiac surgical arena, and the mid-cap, off-cap now, robotic, minimally invasive surgery, angiogenesis, stem cell, whole host of new technology. Anesthesia, we evolved with inhalation anesthetic, refine the outcome, pharmacology, monitoring, technique, pain management, fast track early extubation is the standard now, ultra fast track to bypassing the ICU. I'm fortunate to work with one of the pioneer and innovative surgeons as well, Tyrone David, with me for over more than a decade at Toronto General before I moved to London. And the timing, as Dr. Mac was indicate, when Dr. Stephen Westerby from UK came to present to us a series of observational patients that they can bypass the ICU because of cost containment in the 80s. At that time, I able to convince Tyrone that with the 10 cardiac surgeons, allow me to randomize, control early versus conventional ventilation in our ICU. And that's the past. 1996, we published a randomized control trial, cost benefit 1 year follow-up, cost reduction, and then all the outcome sustaining the change in practice. We continue to inspire to our team in the periop cardiac arena to raise the bar for evidence-based and decision-making in all organ protection, either be in the brain, echo, kidney perfusion, infection control, bleeding, coagulation. I have a fortunate relationship working with many of the brilliant and innovative surgeons both in ISMICS and the European Society as well. This one with Marco Torino, that he invited me to work on some of the type B dissection work on the stent that allow us to change and use it for some of the guideline and statement in the guideline in the ACC as well, or the European Journal. We also work with the WHO, some of the work we use for surgical mortality and anesthesia mortality. And actually last week I was at the WHO, put in the resolution, helped to draft some of those, and it will be in the resolution for emergencies, essential surgery, and anesthesia care in the WHO. So we've been fortunate to continuing moving some of the evidence base in all different arenas. So how was it started? This is back in the 2004, when I got a phone call from one of the, at that time, to see if I got his picture here, Dr. John Pukas. So he apparently was reviewing my papers submitted to anesthesiology when one of our top journals asked me to actually look at this meta-analysis and evidence base regarding using it for the first CME activity for our leading journal. So after his review to our paper in off-cap, the very first one for randomized controlled trial patients, I got a call from him and invited me to look at and work with ISMICS regarding how we can do some consensus conferences. And some of our work has been externally validated compared to some of the very high, big organization ran, UK, the NICE program, our quality actually independently validated as one of the top quality in that aspect. So with John's encouragement, one of my fellow Canadian surgeons, that I got convinced and introduced to ISMICS in 2004. And that's our first ISMICS consensus published on low risk, on the low risk and also the high risk patient for both level A and level B evidence. At that time, innovation is going through, working through the Medline Index. I was convinced and helped the ISMICS Society and the innovation. I was told and I was led to believe 2 years, work with us for 2 years and we'll get things done and will help us to get this as much for the consensus leading practice so we can get index. So about 8, 9, 10 years from now, we got that done finally. So 2004 to 2014, as indicate, we all want new toys, whether it's a technological search or whether there's a big enthusiastic approach. We all want to embrace change. But often enough, we overuse, overestimate the complexity of the patient, and we might have a trough of dissolution. So we really have to find a soft spot for us to sustain a technology in the current practice. So our consensus development is a very tight and rigorous one. We have assembled a panel. We search all relevant evidence. We don't cherry pick. We did a comprehensive systematic review and meta-analysis. Each outcome that we pick on, especially the clinical mortality relevant outcome. And then we make statement only based on evidence and make explicit level of evidence in the publication and derive the recommendation. And we draft that consensus, the term of reference, and some of those in the journal, in the ISMIC. Of course, this is the first consensus off cap in 2005. We follow with the endoscopic venous harvest back in the time when Keith Allen is leading. Many of the surgeons you know of might be sitting in this audience as well. And then we follow with the transmyocardial laser, another interesting evidence that we look at. When this technology come out, the principle in theory is good, that we create open channel. Unfortunately, they don't sustain. Doesn't matter how we shoot the laser in or the laser out or using needle, doesn't work. Then we have the thoracic surgery for the video assist. The surgeon there, the leading surgeon there as well, Robert Downey, obviously, and the stent and stenous biostatistic aortic valve, John Pepper from UK. And then we have the surgical atrial ablation for AF by NIF, and the minimally invasive with Volmer is one of the highest actually cited and quoted paper in the ISMIC as well. And then with Allen, we have one of the probably a big chunk of analysis. This one we didn't realize until I looked into the data, because we look at the drugs, technology, device, and technique. It's like 3 meta-analysis and consensus together. So it's a huge big work that we have to do on that one. And then in 2012, we have done the TAVI, led by Gregory Fontana. And as a matter of fact, we have the paper actually submitted to him in September 2013. But at that time, he was warning us there's a new paper coming out. So he has been holding that until we have a new data. And then last year, we have with John again, go full circle. Back in 2013, we have the ISMIC off cap. So after a look at the 8 published consensus conference, and I'll update to you the other 2, out of the 8 published consensus, we have over 313 clinical outcome, relevant outcome that we have analyzed. The sobering factor is that out of 1 million patients we saw in the minimal invasive surgery world and in ISMIC analysis, less than 1% are from RCT. Many RCT number, but they have very small sample size. Most of them are level B observational study. 8 consensus conference, 64 surgeon involved, perfusion, multidisciplinary consultant in there, 293 comparative study we have done, over 1 million patients we have seen, over 313 outcome. We make 69 recommendations from ISMIC Society. The key thing though, 55% of those are based on level A evidence. Despite they are small randomized controlled trial, at least the quality is improving. We're based on rigorous evidence-based approach. 55% level A, 36% are level B, 9% level C only. 69 of those recommendations. In contrast to the Bible of cardiac science, ACE, the circulation, 11% of those are level A evidence. If you read the circulation guideline back in the 2010 when they analyzed those data, 48% of those are level C evidence. So you look at the consensus and the innovation that we have published for the last 10 years or so. The innovation now is truly international, globally accessible. The top articles, most of those are from the consensus conference and consensus statement. The top viewed article in 2013, 6 of those are the consensus statement and consensus conference. In the innovation, in the OVID, top article being cited or being looked at, again, is the consensus statement that position 1 to 9 and 10. And all of those, the view are being denoted here. Not only that, the view is being denoted in the 3-year process, over 1,000, 3,000, 2,000 people viewing those. The key aspect is the citation. The citation for those used in their study, in all the other work, in their review, are cited from innovation. So what are the updates for the other 2 that has been now on hold for a little bit? When we charge with looking at the TAVI, which is an emerging technology, we are posed with 2 questions. TAVI versus open surgery, to assess if that time femoral approach and the transapical approach improve for those patients that are eligible for surgery. And then we also look at TAVI and medical management for those patients who are ineligible for surgical operation. As Dr. Mack indicate, we have looked at all those 4 long-term outcome papers. We look at the European trial, and also we went to the FDA data bank to look at some of the registry data as well. And we have more than 44 studies, 3 RCT and 41 non-RCT. The outcome, all-cause mortality at 30 days. For the RCT, in the surgical, 6%, 4%, not much different at all. All-cause mortality for TAVI versus surgical opening, 24, 27%. Keep that number in mind because you're going to see some of the new data in the latest publication as well. However, when there's not randomized control, the data change, especially in the surgical. So there is some overall, if it's level B evidence, there are some bias in the selection. You can see they are much lower incident of 1-year mortality. All-cause mortality, they are much more equal afterward. There are concerns when we look at the literatures at that time for TAVI regarding the transapical approach versus the open approach have a higher incidence of stroke rate compared to the open procedures, and more so in the transapical versus the transfemoral. But the transfemoral have its own other intrinsic complication regarding the vascular complication, particularly during the first generation of the device. So at that juncture with the consensus team in 2013 September, we put in the document, although the statement recommendation, although mortality is similar in the eligible surgery, TAVI may not be routinely recommendable because of the risk of stroke and aortic regurgitation. Class 2B and level B recommendation. However, because of the 2 new trials that were told that we should hold off and wait until these 2 trials that we now try to extract the data. This is a single leg arm trial. It's not a randomized control. Despite some people might think this is a randomized control trial, this is a single arm study. 1-year mortality 26%. Instead of the perceived anticipated 43% high-risk patient, they're not really as high risk as being anticipated. Also, a randomized control trial did publish by David Adams in the New York is indeed indicating the mortality are quite reduced, significantly reduced in the TAVI versus the surgical open. But you can see here in 1 year, they are less than 20%. So the patient is not as advertised as high risk as in the publication. So nonetheless, so we are in the process now to extract some of this data to add in and redo some of this analysis, and then the recommendation will come forward. But keep in mind the TAVI versus medical management. Don't forget that group of patients that we allow them to go back, have a 1-year mortality, medically treat, 40% mortality. If they are deemed to be not surgically fit, the mortality is 40%. So for that particular consensus, I won't bother you with 200 forest plot. This is the summary data. TAVI versus medical management. There's increased risk for the initial intervention for TAVI versus medical management. Increased 6 stroke within 100 patients, but reduced from 40% to 30% mortality in the 1 year. So it's in reducing 20 deaths in 100 patients. When those patients survive the procedures, their New York function improve. They used to be grade 3 and 4, and now they're grade 1 and 2. When they success, their quality of life improve. So the ISMICS recommendation in TAVI versus medical management for those patients that are ineligible, actually the choice between TAVI and medical management between a trade-off between the risk increase for the intervention for initially versus the improved 1-year survival and clinical status and resource utilization. Class 2A recommendation, level B. More important, like any other procedures, we need the learning curve. Make sure that we have the right timing, as Dr. Mack indicate. We can't jump into the technology and technique too early. So we need at least a 50 patient to have a plateau of complication in 30 days, about 55 to 58 for 1 year plateau of the complication. We contextualize that in our own institution, the London Health Science, with Dr. Michael Chu and Dr. Bob Ki. We look at our TAVI and standard procedures, contextualize to our own hospital setting, i.e., for those medical patients that send back home, they become a frequent flyer back to our clinic for heart failure management, renal problems, emergency visit. When you calculate the quality, cost effectiveness, actually is beneficial. So TAVI versus management, this population actually is worth the while to invest if you have the team to invest in those. How about off-cap? The data might change. This is 10 years ago, when 400-odd surgeon was being asked, if you yourself have 4-vessel or 5-vessel coronary bypass revascularization requirement, who do you want your peer? Look to your left and look to your right. Who do you want to operate on you for your bypass? A surgeon only know how to do bypass on pump, or only know how to do both off-pump bypass, or going to competence in both. 75% of you say that you want someone of your peers to be capable in both procedures. So off-cap, we're able to revisit this on the RCT and non-RCT since 2005. That's because we have there are 5 very large trials being published since 2009 and our last consensus. The best bypass surgery on off-pump, the Danish trial, the coronary trial in Hamilton, and GOPCAP trial in Germany. You can see the number of patients. Those are all high-risk patients. So we have more than close to 20,000 patients in off-cap. Probably this is the largest of evidence in off-cap surgery looking at some of the outcome, 102 randomized controlled trial. The recommendation compared to conventional coronary bypass, it is reasonable to perform off-cap to reduce the risk of stroke, class 2A, level A, to reduce the risk of renal dysfunction, blood transfusion, respiratory failure, AF, wound infection, and resource utilization. But bearing in mind, there might be association, might have a 0.5 or 0.6 reduction of the graft of number being grafted. Clinically significant, not, we don't know yet, but reduced graft patency indeed show up in the evidence and increase re-intervention in 1 year. And up to 5-year follow-up, they might have slight increase in the mortality. So looking at the last 10 consensus, 8 published and 2 in the work of going, what are the take-home message? I think for the reflection for 10 years, we accomplished what we set up to do, or my commitment to the society, but also to many of my good friends in the room here, that we have one of the best journal in citation for innovation, technology, technique, compared to any of the journal in the current literatures. Some of the top quoted, cited top papers being read are from the consensus statement. Innovation now we achieve is a Medline Index journal. We accomplished that. But when we're moving forward and we look at new technology, when we want to investigate a new one, it's better in the last 10 years, but critical gaps still exist in our world of minimally invasive surgery. There are still operator dependence and learning curve. We make sure that in the right timing before we do the study. We need to account for some of those guidelines. Short-term study, sometimes we're too premature to measure relevant outcome and try to publish a paper. With loss of follow-up, it's not detailed enough that the crossover often enough are not being defined by the author. So I preach all of you to, when you do your study, document explicitly in your trial the data so that we can follow through regarding crossover, non-comparative report, and non-randomized study. So study design is important that for us to move forward, make sure that for intervention as much as we can, do the randomized controlled trial. When we develop consensus in the future, before we jump into any other commitment, we need to ensure we look at the risk, the benefit, and the opportunity cost that for both of us to continue and moving forward. Many of you may not know, because some of you, because I work with different group of surgeons, in the past 10 years, we have probably subsidized from my own team and time for the 10 systematic review and meta-analysis for a real value of over $1.5 million in people resources, the time that we invest for the last 10 consensus conference. As I mentioned, that you saw some of the things we've been doing with the outside, with the other organizations and the government and even WHO. These are within a rapid scoping on literatures. It's about 50 grand to 75 grand. For a full systematic review, it's 150 to 200 grand. If you go to the UK economics group, which we have visited the last month, their going rate is about the same because some of the work we have to contract out and they're charging an arm and leg for our program as well. So these are the investment that actually we commit to the society that I hope that people understand. So in moving forward, for the society and our program, I really need to understand more deeply for all of us regarding the resource, the time and opportunity cost, and we probably cannot do annual consensus, but selective ISMIC consensus for the right procedures, right innovation, and the right skill set together. So I thank you.